Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you back to another important lecture. Today we are studying the anatomy of orbit. In this video we shall be studying about the various bones which form the orbit, the different walls of the orbit, the relationships of the orbit to its surrounding structures, important landmarks which are present in the various walls of the orbit, and the relevant clinical nuggets. So first of all, what is meant by orbits? Orbits are present bilaterally. That means we have two orbits in the skull, which are these empty spaces which are actually in the form of a truncated pyramid. And these are the spaces which actually house our eyeball along with the various appendages which come along with the eyeball. So if you consider this first picture, this is a picture of a whole pyramid, right? Now if you cut off the pointed top portion of the pyramid, what you get is a truncated pyramid, and this is what is exactly the shape of the orbit. The orbit is placed in such a way that this uppermost truncated part is actually the apex of the orbit, okay, from where the optic nerve will actually exit the skull, and then this part is the opening of the orbit, and then we have the corresponding walls of the orbit. So this will be the medial wall, this will be the lateral wall, this will be the roof, and the part which is just behind that will actually form the floor of the orbit. So don't get confused at this point. We shall actually be discussing about the walls of the orbit in detail, but what I want you to remember at this point is the shape of the orbit, that the shape of orbit is a quadrangular truncated pyramid. Let us now talk about the various relations of the orbit. If you actually take the skull and you actually divide it from top like this, and you dissect or you cut open the skull of a person, you will see three cranial fossa. So we have an anterior cranial fossa which is present anteriorly. Okay, so if this is the nose and this is the eye, this is called the anterior cranial fossa. Then we'll have the middle cranial fossas, okay, and then posteriorly we will have the posterior cranial fossa. Okay, so this background information is very important to understand the relationship of the orbit, so as you know where exactly the orbits are actually placed in the skull. Now, similarly, you should also know the placement or the anatomy of various sinuses. So we have these two sinuses which are labeled as one in green color, present in the frontal bone, and these are called the frontal sinuses. Then you can see this pink color sinuses which are labeled in two, and these are the ethmoidal sinuses. Then you can see these sinuses which are present in the maxillary bone, and these are called the maxillary sinuses. Now let us discuss the relations of the orbit. Okay, so now it'll be very easy for you. Now we know where are the orbits, so these two are the orbits. So what is related superiorly to the orbit? Superiorly, the orbit is related to this frontal sinuses and also to the anterior cranial fossa. So what did I tell you? That if you actually cut open the skull, what you have here is the anterior cranial fossa, right? So sitting right on top of your orbit is the anterior cranial fossa and the frontal sinus, right? Coming to the medial relation of this orbit. So the medially you can see that it is related to the nose, that means the nasal cavity. And what are those pink color structures present? Those are the ethmoidal air sinuses. Inferiorly, now you can see what is present, the maxilla and the maxillary sinus. Now what about lateral to the orbit? Lateral to the orbit you have these middle cranial fossa along with another fossa which is called the temporal fossa. So I'll explain that to you again when we talk about the lateral wall of the orbit. Now, coming to the direction of the orbit. So, if you consider these two to be the eyeballs, okay, and this eyeball is located in these orbits. As I told you, the orbits are actually in the form of a truncated pyramid. The orbits are placed in such a way that the lateral walls of the orbit, so this is one lateral wall and this is another lateral wall of the orbit. These lateral walls will form an angle of 90 degrees to each other, and they're also placed in such a way that the medial walls of these orbits will be actually parallel to each other, and they are placed at a distance of 25 millimeters or 2.5 centimeters. So this is very important thing that you should remember. Apart from that, the widest dimension of the orbit is approximately 1 centimeter behind the anterior orbital rim. So what is meant by anterior orbital rim? So if you see, if this is the orbit, Okay, the most anterior part of the orbit is called the rim or the anterior orbital rim. So if you go just 1 centimeter behind to that rim, that will form the widest dimension of the orbit. Another important clinical point that I want you to know is regarding the intraorbital septum, the intraorbital segment of the optic nerve. Now, I already have a video on the channel regarding the anatomy of the optic nerve. So, in that, I told you that the segment of the optic nerve which passes from the eyeball to the optic foramen is called the intraorbital portion of the optic nerve, right? Now, this intraorbital portion of the optic nerve actually has an S-shaped curve. So, okay, it has a sinus path in the intraorbital portion or in the orbital portion. Now, the important or the relevance of this point or nugget is that this sinus path of the intraorbital part of the optic nerve actually allows the eye to rotate freely and to move forward with some kind of freedom, and therefore without placing any excessive tension on the posterior globe where the optic nerve is inserted. So what I mean to say is, if this optic nerve had a very straight and a taut path, what would happen is whenever you move your eyeball, the optic nerve will also get stretched, and that will cause some amount of tenting or stretching on the eyeball. However, nature has developed this, nature actually prevents this from happening by giving a sinus course to the intraorbital part of the optic nerve. Now let us talk about the important orbital dimensions or the measurements which are commonly asked in the exams. So what you commonly are asked is about the volume of the orbit. So the volume of orbit is about 30 centimeter cube or 30 ml. Coming to the height at the entrance is about 35 millimeters. The width is about 40 to 45. The medial wall length is about 40 to 45. The distance from the posterior globe to the optic foramen is about 18 millimeters. And the length of the orbital segment of the optic nerve is about 25 to 30 millimeters. So here the three important dimensions are the volume, the length of the orbital segment of the optic nerve, and the distance of the posterior globe to the optic foramen. Coming to the walls of the bony orbit properly, so as I told you, the walls are the roof, okay, the upper, the superior portion of the orbit is called the roof of the orbit. Then the inferior portion is actually called the floor of the orbit. Then we have a wall which is present inside, that means towards the nose, and that is called the medial wall of the orbit. And then we have another wall which is present laterally, and that is called the lateral wall of the orbit. First, let us talk about the roof of the orbit. So, the bones which form the roof of the orbit are the orbital plate of the frontal bone and the lesser wing of the sphenoid bone. The first picture over here shows you the sphenoid bone. If you actually observe it carefully, it looks like a bird. So, you have a bird with the central body and then the wings, right? The inferior larger wing is called the greater wing of the sphenoid, and the green color wing, which is the smaller one, is called the lesser wing of the sphenoid. And in between the two, you have the superior orbital fissure, right? That's again a very, very important structure. Now, it is the lesser wing of the sphenoid which is present superiorly in the sphenoid will form the roof of the orbit. Coming to another bone which forms is the frontal bone. So this green area entirely is a frontal bone. You can see a part of the frontal bone is actually bending inside the orbit, and that is called the orbital plate of the frontal bone. Okay, so these two bones will form the roof of the orbit. These are the orbital plate of the frontal bone and the lesser wing of the sphenoid bone. Now this picture is just to show you the orientation of the sphenoid. So you can see here also from the lateral part, you can see some part of the sphenoid, okay. And in the second picture, you can actually see the what I have marked over here is a lesser wing of the sphenoid. So what did I tell you? That the greater wing of the sphenoid and the lesser wing of the sphenoid will enclose a fissure which is called the superior orbital fissure, and the lesser wing of the sphenoid along with the frontal bone, that is this part, will actually form the roof of the orbit. So that is very important. Coming to the important landmarks which are present in the roof. In the roof, you have three important landmarks which should be remembered. So the first is the fossa or the space for the lacrimal gland, okay, which will actually harbor the orbital lobe of the lacrimal gland. the trochlea of the superior oblique tendon, which is located about 5 millimeters behind the superior nasal orbital rim. Now, I already have a video regarding the superior oblique muscle, and in which I have explained to you in detail regarding the trochlea. The third important landmark is the supraorbital notch or the foramen, which will actually transmit the supraorbital vessels and the supraorbital branch of the frontal nerve. Now, this third landmark also becomes important when you actually give a superior blocks or the superior peribulbar block. So this is the video in which I explained to you in detail regarding the obliques muscle and superior oblique and its trochlea. Now this picture over here actually depicts the various landmarks in the superior wall of the orbit or in the roof of the orbit. So you can see laterally you have this fossa which will actually harbor the lacrimal gland. Okay, so lacrimal gland is located in the lateral part of the roof of the orbit. Then we have this central landmark which is the supraorbital foramen and or also called the supraorbital notch. Then superior nasally 5 millimeters behind the rim. So this is the anterior border which is called the rim. So about 5 millimeters behind that rim you have another landmark which is called the trochlear, okay, which will actually harbor the troch. Now let us try to understand the various bones which form the medial wall of the orbit through this diagram. Consider this to be a skull of a person in which we have dissected the skull in this manner, and we have now removed the lateral wall of the orbit so that we can have a direct view at the medial wall of the orbit. So through this diagram you are actually looking straight into the medial wall of the orbit. Now you can see there are so many bones which are actually forming the medial wall, and according to the mnemonic that I told you, there are about 4 bones which will form the medial wall of the orbit, right? So what are these 4 bones? First is the maxillary bone. So you can see this bone over here. So this is coming from the maxilla, and because it is growing towards the frontal bone, this process seems to be growing towards the frontal bone. Therefore, this entire thing is called the frontal process of the maxillary bone, right? So the frontal process of maxillary bone you can see is forming the medial wall of the orbit. Now apart from that you can see a bone which is present just behind that, this rectangular bone, and this is labeled as the lacrimal bone. It is called the lacrimal bone because it harbors the lacrimal sac. Behind that again one more rectangle shaped bone you can see, and that is called the ethmoidal bone. And behind that what do we have? We have this lesser wing of the sphenoid. So this is the sphenoid bone and we have a lesser wing of the sphenoid. This lesser wing of sphenoid you can see it is also extending superiorly, and we know that it also forms a part of the roof of the orbit along with the frontal bone. Now this should be more clear in this diagram. You can see the green one is the maxillary bone, and to be more specific, it is the frontal process of the maxillary bone. The purple thing or the violet thing is the lacrimal bone. The blue color labeled bone is the ethmoidal bone, and the pink one is actually the sphenoid bone, or the lesser wing of the sphenoid bone, which is forming the medial wall. Now, one more important point that you should remember is that the medial wall of the orbit is located just adjacent to the ethmoid and the sphenoid sinuses and the nasal cavity, right? So we know that here will be your nose, and in the nose and around the nose you have the ethmoidal sinuses, and this medial wall is in very close location to the ethmoid sinuses and also to the sphenoid sinus which is present over here and to the nasal cavity. Now, one more thing which I want you to have a look over here is the optic canal. So what is optic canal? Optic canal is an opening through which the optic nerve will actually exit from the orbit. And you can see that this optic canal is actually located in the medial wall of the orbit. Okay, so the medial wall of the optic canal is also formed by the lesser wing of the sphenoid. You can see this opening is actually present in the lesser wing of the sphenoid, which is present in the medial wall of the orbit. And therefore, if someone asks you where is the optic canal present, the optic canal and specifically its medial wall is formed by the lesser wing of the sphenoid. So that should be clear. Now, just a mention about the ethmoidal bone or the orbital part of the ethmoidal bone. So as I told you that the medial wall of the orbit You can see this is the medial wall, and you can see it is in very close proximation to the nose and also the ethmoidal sinuses. All those circular things over here, what you see is the ethmoidal sinus, and this uh, large bone what you see is actually the ethmoidal bone, right? So you can see there are various parts of the ethmoidal bone, but what is important for us is that the lateral part of the ethmoidal bone will actually form the medial wall of the orbit, okay, and it is in close approximation or close proximation to the ethmoidal sinuses, and this is the reason why ethmoidal sinus infection can actually spread into the orbit as well. So this gives you an important clinical nugget, and that is the thinnest wall of the orbit is also that of the it's also the medial wall, and specifically it is the ethmoidal bone which is the thinnest bone in the orbit, and because it's so thin like paper, it is called the lamina papyracea. Okay, it is present between the orbit and the ethmoidal sinuses along the medial wall. So this part is the ethmoidal sinus, and this is the ethmoidal bone. This bone is very thin and it's also called the lamina papyracea. Apart from that, one more weak area is the posterior medial portion of the maxillary bone, right? And therefore many times you are asked questions like which is the thinnest wall of the orbit. So the thinnest wall of the orbit, also the weakest wall of the orbit, is the lamina papyracea or the medial wall of the orbit. Whereas which part of the orbit is more prone to developing a fracture post blunt trauma? So the answer should be the floor of the orbit, which is which is actually to be more accurate, it is actually the junction between the medial and the floor of the orbit, and specifically the posterior medial aspect of the maxillary bone, which often gives away during a blowout or injury to the orbit. Now, another important clinical nugget over here is that the acute bacterial infection of the ethmoidal sinus sometimes may extend through the ethmoidal bone to the neurovascular perforation. So you can see these two holes which are present in the medial wall, and these are the anterior ethmoidal foramen and the posterior ethmoidal foramen. And many a times you will see that the acute bacterial infection of these ethmoidal sinus, which you can see over here in this radiograph as well, can actually extend to the orbit below the periosteum of the medial wall, and that will form a medial subperiosteal abscess. Now let us talk about the floor of the orbit. The floor or the inferior part of the orbit is formed by three bones, and here it is number one is the maxillary bone. This everyone can remember because we know it's a big bone sitting on the inferior aspect of the skull. So the maxillary bone forms the inferior part, and then we have a very small contribution from the palate bone, which is also called the palatine bone, and then laterally we have this bone which is called the zygomatic bone. So this zygomatic bone also gives an inward extension into the orbit, which is called the orbital plate of the zygomatic bone. Okay, so the three bones which are forming the floor of the orbit are the maxillary bone, the palatine bone, and the orbital plate of the zygomatic bone, and this can be remembered with the mnemonic MPZ. So the floor of the orbit again is depicted in this first picture. It is as if you have taken a cut section. So you can see here we are looking from top to the floor of the orbit. You can see this is the laterally is the zygomatic bone, and this is the orbital plate of the zygomatic bone. This large thing over here is actually the maxillary bone, and a very small portion is actually contributed by the palatine bone. And this large fissure that you can see is the inferior orbital fissure. So the inferior orbital fissure in this view is here, and if you look from top, this is how an inferior orbital fissure is going to look like. Now, an important clinical point regarding the floor of the orbit is I told you that the floor of the orbit is most likely to develop the fracture, and this fracture happens in the posterior medial aspect of the maxillary bone. And this important clinical sign that you see on the radiograph is a teardrop sign. Okay, so you can see this giveaway of the floor of the orbit, and you can see the intraorbital contents actually protruding into the maxillary sinus in the form of a tear, and therefore it is called a teardrop sign. Similar thing is seen in this radiograph as well. Now, what are the important landmarks if you ask in the floor of the orbit? I already told you it is the inferior orbital fissure. Apart from that, it also has a groove and the intraorbital canal, which will actually transmit the infraorbital artery, and the maxillary division of the trigeminal nerve. Now let us talk about the thickest and the strongest wall of the orbit, that is the lateral wall of the orbit. And the lateral wall of the orbit is formed by two major bones, the lateral bone, which is called the zygomatic bone, and then we have the greater or the bigger wing of the sphenoid bone, right? And I told you that the lesser wing and the greater wing were actually separated by the superior orbital fissure. So now again we will use this diagram. So this smaller one, we knew what was this? This was the lesser wing of sphenoid, and the lesser wing was actually forming the part of the medial wall and part of the roof. Now again, this bigger yellow structure over here is the greater wing of the sphenoid, and this greater wing of the sphenoid is going to form the lateral wall of the orbit. Apart from that, you already know that this big bone over here is the cheekbone or the zygomatic bone. This zygomatic bone again was giving an orbital plate inferiorly and forming the floor. You remember? Yeah. Now the same zygomatic bone will also give one more orbital plate here and form the lateral wall of the orbit. So the lateral wall of the orbit is formed by the greater wing of the sphenoid and the zygomatic bone. So you should know that this is located adjacent to the middle cranial fossa. So the middle cranial fossa will be somewhere located here inside the skull, and then over here you have this space or a hollow temporally, which is called the temporal fossa. So the lateral wall is actually in relation to the middle cranial fossa above and the temporal fossa. Now the lateral wall is in such a way that it extends anterior to the equator of the globe, and therefore it actually protects the posterior half of the eyeball. Now, what are the various important landmarks or important points which are present in the lateral wall? The most important landmark in the lateral wall is the lateral orbital tubercle of Whitnall. And this Whitnall tubercle actually has multiple attachments, which I shall be discussing soon. Now, another important thing is a Whitnall ligament. Okay, this Whitnall ligament inserts onto the lateral orbital wall several millimeters above the lateral orbital tubercle via attachments to the lacrimal gland fascia. So here, what I want you to remember is that the Whitnall tubercle and Whitnall ligament are not same, and Whitnall ligament does not insert on the tubercle of Whitnall. Another important landmark is the frontal zygomatic suture, that is a junction between the frontal bone and the zygomatic bone, and this is located 1 centimeter above the tubercle. Now this picture actually shows you the bones which are present in the lateral wall of the orbit. So as you can see, this is the greater wing of the sphenoid, and over here you have the zygomatic bone. Now this picture is also showing you the various landmarks. So we have a big tubercle or protrusion on the lateral wall, which is called the lateral orbital tubercle of Whitnall, which will have a lot of insertions on that. But remember, the Whitnall ligament does not insert on the Whitnall tubercle. It actually inserts somewhere superior to that. And then we have a suture or a junction between the frontal and the zygomatic bone, which is called the zygomatico-frontal suture. So what are the various structures which are attached to the Whitnall tubercle? The Whitnall tubercle is basically, if you notice, is attached to structures which start with L. So it is lateral canthal tendon, lateral horn of the levator aponeurosis, the check ligament of the lateral rectus, and the Lockwood ligament, which is also called the suspensory ligament of the globe. So this diagram actually shows you the various attachments of the Whitnall tubercle or the lateral tubercle. So this Whitnall tubercle will be present here. So you can see the canthus. This is the canthus where the superior and the inferior lids actually meet together. It's called the canthus. So you can see a tendon inserting from the lateral canthus to the tubercle. This is called the lateral canthal tendon. Right now, the levator will also have the aponeurosis. It will have a medial attachment and a lateral attachment. The lateral attachment is called the lateral horn of the levator aponeurosis, and that is also attached to the Whitnall ligament. Apart from that, you have two more things which are called the check ligament of the lateral rectus and the Lockwood ligament or the suspensory ligament of the globe, which is not shown in this diagram. Here, if you can see this fibrous white condensation on the levator aponeurosis, which is called the Whitnall's ligament. If you see carefully, the Whitnall ligament is not really inserted at the Whitnall tubercle. However, it is somewhere inserted near the frontal zygomatic suture. Now this picture over here actually shows you the suspensory ligament or the Lockwood's ligament, which also gets inserted at the tubercle or the lateral tubercle of the Whitnall's tubercle. Apart from that, you have this lateral rectus, and a part of the lateral rectus ligament, which is called the lateral check ligament, is also inserted on the tubercle of Whitnall. So the four structures which are inserted on the Whitnall tubercle are lateral canthal tendon, lateral horn of the levator aponeurosis, the check ligament of the lateral rectus, and the Lockwood ligament. So with this we end, but I will leave you with a question. You have to identify the muscle, identify the bone which is actually marked over here, okay, and give the answers in the comment section. So that's all for today. Thank you and have a nice day.